Now we'll move on to next talk by Dr. Durga Rao, going to speak on keynote address on enhancing success of IVF treatments, role of advanced fertility interventions. After listening to Mr. Sudhakar about the journey of Oasis, it's really great to see the way Oasis has evolved over years with its hard work, commitment, dedication towards patient care and providing world-class treatment for all types of fertility issues with so many branches across the world. Oasis has been very active in conducting many academic activities. I would like to congratulate the team. Wish them good luck for further future endeavors. It's my privilege to introduce Dr. Durga Rao. She's a very good speaker with immense depth of knowledge and passion with fertility, field of infertility. And Durga Rao is a co-founder and medical director. And Durga Rao is a specialist in reproductive medicine and minimally invasive surgery over last 18 years. And she practiced in the United Kingdom before coming to India. And she's underwent her professional training in UK, has several papers submitted, publications associated with reproductive medicine and minimal invasive surgery. And educational qualifications, she did her fellowship in infertility and reproductive endocrinology from McGill University. And she's a member of RCOG UK. And she did her DGO from University of Health Sciences. And she passed MBBS from Andhra University, Andhra Pradesh, India. And Madam specially, she came to India, moved from UK to India in 2009 specifically to make available modern treatments in reproductive medicine to couples. I request Madam to come and deliver a lecture.
Thank you, Madam. Thank you very much for the introduction. The reason why we thought of actually speaking about IVF and its journey and the advancements that have been coming with this field is because, frankly, not a lot of us are aware of where this field is taking us. Obs and gynae obstetric is from time immemorial that, this field has been there. But when we are really looking at reproductive medicine, we're only talking about 4 decades of it. But in these 4 decades, there's been a huge jump in terms of what we are able to achieve. So the first birth, as we all know, was in 1978 with Louis Brown. And when you look at how she was conceived, it was basically an egg pickup that was done through laparoscopy. One embryo, 8-cell embryo, put back in a fresh transfer, and then, she was born. Since then, there has been a huge journey. But what we always have to remember is that there are certain guidelines through which we have to work. And we should never forget that even if it is a fertility patient, we have to look at the basics first. And when we are talking about fertility practice, every aspect of that couple is important to us. We have to pay special attention to the age of the woman, particularly if she's more than 35, what are the issues that she's going to be coming with? How do we address them before we actually start our fertility treatments? Does she have any medical problems? Does she have any surgical problems that have to be addressed before she conceives? And obviously, in today's world, obesity and the lifestyles that we have, how do we correct that? How do we change that? It is not difficult for us to get a BMI of a 42-year-old woman pregnant. That's fine. But what happens is after she comes to you, that's when the trouble begins. So just because we are fertility specialists, we can't say, fine, you're 40, it doesn't matter, we'll get you pregnant. We have to think about the fact that our goal together is for the mother as well as the baby to go home safe. So these are the addresses that we actually think about before we even start fertility treatment. And again, looking at how the society is nowadays, in terms of all the lifestyle factors that are affecting us, we have to take care that we give them the right advice when it comes to smoking, when it comes to recreational drugs, or even alcohol and binging. This is where preconceptional counseling still has a mainstay in terms of management of an infertile couple. Now, as we are talking about advances, we just want you to be aware as to where we are in terms of reaching our goals for an infertile couple to get pregnant. Now, this was a paper which was extensive, and the most important aspect of this paper, which I thought would be important, is For us, but this is for women who are more than 35 years old. And the reason why I picked up this paper for us to understand is getting a woman pregnant who's less than 35 is a pretty easy effort. Our skill comes in getting a woman who's more than 35 pregnant. But then what are the challenges and what are the parameters that would enable a couple to conceive once they cross 35? If you can see, if you have 5 embryos put back, the chances of that woman conceiving is 40%. We are talking about embryos, we are not talking about oocytes. So if I have 5 embryos, there's a 40% chance that that woman will conceive and go home with a child. And if you have 10 embryos, there's a 70% chance that that woman will go home with a baby. So looking at the number of embryos, what we have realized is there is still a long way to go for us to reach that level of efficiency where we can get a woman pregnant with just 2 or 3 embryos. We are still stuck at this number. Now, this is where we started off. Now, looking at where we are, what is it that we are expecting in terms of advances when it comes to ART? Now, let us look at the pharmacology first, because when it comes to IVF, more than the protocols, it is the drugs that actually enable us to create the oocytes, develop the oocytes, and extract them. So when we are talking about the advancement when it comes to pharmacology, what is actually very disturbing for a woman, the first thing about an IVF is she has to have injections every day. For her, that is the most troublesome aspect. Even egg retrieval is okay for her because we are giving her anesthesia. But getting injections, even though they are subcutaneous, every day 3 or 4 injections is the most troublesome and the most disturbing aspect. And this is one thing which actually makes a woman delay her fertility treatment. So when we are really looking at advancements, the first thing that we wanted to do is to see whether we can reduce that burden. And one of the injections that is going to very soon come into the market is corifoliotropin alpha, which actually enables us to give one injection, and that one will last you for a week. Which means that you'll only need another 3 to 4 days more of injections, and then she'll be done with her stimulation. So this is really going to enable women to actually reduce that burden. We are also looking at other developments here. When we are talking about, Recagon or even Gonal-F, these are the recombinant FSH. But how are these recombinant FSH developed? They're coming from the hamster cell lines, which again means that is coming from a different species, which again has some immunogenicity issues and potential. So what the science and research has done is to bring about different kinds of hormones, which are recombinant, but are coming from the human cell line, which will make them more effective, less immunogenic, and therefore much more effective. We are also looking at different kinds of these hormones, which are going to reduce the dosage that is going to be given, as well as make the stimulation much shorter. We are also looking at making them cheaper, because that's the second burden that we have, is the finances that are associated with the fertility treatments, particularly IVF. So here we are looking at going for biosimilars, which means that these hormones are going to be produced completely in the factory setting. We are not going to require any kind of cell lines, but they'll have the same kind of efficiency and efficacy, which then drastically reduces your cost. Now, there's a lot of research going on in this. There are a lot of studies also that are slowly being published about these biosimilars, but they still haven't replaced our traditional recombinant injections so far. Now, KISSPEPTIN, this is a hormone that is being produced by our hypothalamus, and an extremely efficient and effective hormone. Now, if this comes into our pharmacy to help IVF patients, we are going to completely eliminate OHSS. We have come a long way actually in reducing our complications of OHSS by using agonist as a trigger. But if we have KISSPEPTIN, that is going to completely eliminate the concept of OHSS. Not only that, it will also reduce the number of immature oocytes that we sometimes tend to have when we are doing oocyte recovery. and also increase the number of more M2 oocytes. So this is also something that is there, but only being used in some research setting and in some centers. But again, this is something that we are going to be looking forward to in the next 5 years. Now that was as far as drugs are concerned. But there has been a great sea change when we're talking about stimulation protocols as well, when we're talking about IVF. It is no longer traditional agonist and antagonist. You get your period, then we start the treatment. No longer that. In fact, we are at that stage where we can start stimulation at any part of her menstrual cycle. We can do a random start at any point. And that is something which is very, very important for people who need fertility preservation, particularly the women who are diagnosed with malignancy and need to actually conserve their and preserve their oocytes before they go for any kind of gonadotoxic therapies. Now, random start, but when we are talking about premature ovarian insufficiency or people who have extremely poor ovarian reserves, for them, dual stimulation has become an extremely good way for us to improve the chances of pregnancy. Because going back to the previous slide, we said we actually need somewhere between 5 to 10 embryos for them to reach a pregnancy beyond 40%. For us to reach that number, I need more oocytes. For somebody who doesn't have enough oocytes, what do we do to manage that? Dual stimulation. Now, those were the things that we spoke about in terms of different kinds of stimulations and medications. What about the lab? When we are talking about what is going on in the lab, again, there has been a huge change in how things are actually working. We have moved from big, huge AHU boxes to something which is very slim and tender, and just even in a normal room, you can actually have a CODA tower that is going to give you the more purified air that is required for a lab. We have also when you're talking about sperm, it's easy for us to actually evaluate a sperm because it's produced outside and you have different ways of assessing it. But when it comes to the oocyte, unfortunately, we don't have a great deal of understanding as to how an oocyte is unless an embryo is created. But PolScope here has helped us evaluate and categorize an oocyte, and this enables us to actually vitrify only the oocytes which have good viability. Now, again, when we are talking about sperm, there are a lot of options that we have in terms of sperm selections. When you have things in great numbers, unlike in oocytes, when sperms are there in so many thousands and millions, how do you pick out that one particular sperm that is going to give you that embryo that can create a viable pregnancy? Towards that, a lot of work has gone on, and again, as you see, IMSI, which actually helps you to evaluate a sperm at 6,000 magnification, would actually tell you all the ultrastructure of the sperm as well. Now, though this has been there, unfortunately, it has not replaced a good embryologist. Because what happens even with IMSI, even though you're able to pick that one particular sperm, is we have not noticed a great change in terms of live births. The one aspect that it has made a difference in is it is reduced miscarriages. But live births have not increased by the use of IMSI. What about other things? Because IMSI is extremely expensive and very, labor-borne. What about other options that we have? We have something in which we use the concept of hyaluronic acid binding. And here, what actually we do is the sperm, which is surrounding the oocyte, has a connection to the cumulus cells. And that aspect of things are actually utilized in something which is called as a pixie dish. And in here, because of the hyaluronic acid, we have all the sperms which are actually got the least amount of DNA fragmentation to come and attach themselves to this hyaluronic acid. And then we pick up those sperms to inject into the oocyte. Again, has it really changed or replaced an embryologist? Again, not yet. What about MAX, which is the magnetic activated cell sorting? Here as well, the concept is extremely important and very simple, and that is when we use annexin beads, what these annexin beads do is they actually go and attach themselves to these sperms which have a lot of DNA fragmentation. So what they do is the machine actually holds back all the sperms which have got a lot of DNA fragmentation, and only the healthy sperms are then evaluated through the system. And because of this, we have much more healthier sperm. Therefore, your DNA fragmentation is lower, the sperm vitality is better, and fertilization rates and the embryo quality is better as well. Now, what about other things? Frankly, microfluidics is where Oasis is at this point. Most of our consultants seem to find this extremely useful, and it helped them in terms of improving their fertilization rates as well as embryo quality. And this is something even the embryologists seem to think has made a lot of difference in terms of sperm selection. So whenever we have somebody who's had prior poor fertilization or even poor embryo quality, then microfluidics is something that we seem to find a lot of difference in terms of the quality. And the concept is very simple. Again, this is the flow electrophoresis that is being used, and this helps channelize the sperms which have the least amount of DNA fragmentation to be used. So what is the next advantage? Now here, earlier about 15-20 years ago, we said Klinefelter, fine, you need donor sperms. But that is not the situation now. Anybody can go ahead and use donor egg or donor sperm and get a woman pregnant. The technology should be such that we try and get a couple to have their own genetic child. So even in people who have chromosomal problems like this, micro-teaser actually helps us in evaluating and actually extracting the few sperms that they have. In micro-teaser, the surgeon with a extremely good microscope is able to look at where you have the tissue that is more likely to be healthy and have spermatogenesis. We actually tease out that particular tissue, tease the sperms from there. And here, imagine, we are not talking about thousands, forget about millions, we're not even talking about thousands. Here we are talking about only a few sperms. So what can we do to actually utilize these sperms? We have devices now in which single sperms can be frozen. And that's the vitrification device. And this is something that has been routinely used for the last 2-3 years in Oasis, wherein even men with very few sperms, we are able to give them their own genetic child by actually utilizing devices like this. In fact, this is something that we had approached a Japanese company, if I'm not mistaken, Israel. So because the first paper came from them. So it took us at least 6 months to actually organize this device because nobody else was using it in India. We actually went behind them, waited till they shipped us those. And after Oasis started using it, that's when the company actually brought it to India. Now, there's a lot of talk and a lot of hype about the adjuvants and the add-ons that we sometimes use in fertility. That is because we want to ensure that we have the best success rate. So what is it that we can do to help implantation, to help the embryo quality, to help the oocytes and the sperm, whether it works or not? We are very ready to use it because they're spending so much money in an IVF cycle. We say we have to give them the best. So whether it works or not, let's just put them on a list of medications. Whenever you see a woman who conceived with IVF, I'm sure she carries pages and pages of prescriptions with her, a whole huge list. And when they go to the obstetrician, they don't know which one to stop, which one to, continue. So let's look at some of the things that have been used. Now, growth hormone. Now, this sometimes actually, when you speak to anybody outside India, when you speak to people in the Europe or America, they're very scared about using things which have not been actually validated, gone through RCTs, gone through their trials, and then only then, if it's shown to be of benefit, it is brought into the pharmacy, but not in India. Growth hormone is actually used, stroke abused a lot. But in which group is growth hormone specifically utilized? Well, it is for the poor responders. It is basically for the unexpected poor responders, which means that they are young and they have good reserve, but when we are doing the stimulation, they don't end up having a good number of oocytes. So for the unexpected poor responders, for the women who are more than 37, 38, these are the two indications that have actually been proven for growth hormone. But another indication which we have found useful is when you have the resistant PCOS, in which you have to go for prolonged stimulation and huge doses of medication, and ultimately they end up with OHSS. In those people, adding growth hormone to their stimulation regime actually shortens their stimulation, makes your gonadotropins much more effective. And we have also noticed a lot of change in terms of the quality of the oocyte as well as the embryo quality in this group of women. What about ultra-CoQ? Well, a lot of studies have been done, and in fact, of all the antioxidants, I think there are 3 which actually make sense to us. Right now, it is CoQ, it is melatonin, and the third, vitamin D. These are the 3 antioxidants that actually make a difference to a woman in terms of improving her oocyte quality. And a lot of studies have shown that the oocytes, the fertilization rates, the number of high quality embryos are better when we give them these antioxidants. And more important, the cancellation rates are lower and the number of embryos available are also more. DHEA, again, another abused drug, but frankly, to give it credit, it does have a role to play, at least in the poor responders, particularly if you give it to them for at least 2 or 3 months prior to their IVF stimulation, wherein it makes a difference in terms of the oocyte quality. What actually it makes a difference in, it is said, is that it reduces your aneuploidy rates. So the miscarriages are lower in these older women when DHEA is being used. What about etosiban? Now, etosiban is a drug that the obstetricians like because it is one of the things that you use for reducing your preterm labor. But frankly, we have found a use for it in fertility as well, wherein, we have noticed that when a uterus has a lot of contractions during or around the time of implantation, your pregnancy rates are reduced. So to help in, reducing the uterine contraction so that there is no expulsion of the embryo, etosiban is given. In fact, there's a lot of research that is going on wherein we are looking at an oral substitute for etosiban. And that would also reduce the burden of injectables as well as prolonged administration, and an oral tablet will probably do the trick for us. Now, glue, embryo glue. This again, just the word makes a woman very hopeful that definitely the embryo is going to stick. Yes, there has been shown advantages with embryo glue in women, and in fact in our study, it showed that in women with recurrent implantation failures, we have actually made sure that the implantation is much better by the use of glue. And also what is more important is the miscarriages rates are also lower by the use of embryo glue. Now this one concept of chronic endometritis has taken hold in the last 3 or 4 years, wherein this has found to be one of the aspects which was not actually thought of before as being a cause for recurrent implantation failures. Now, the diagnosis is on hysteroscopy, the diagnosis is on histopathology as well as immunohistochemistry. We have to combine all of these modalities to actually come to the diagnosis of chronic endometritis. It is not a very easy diagnosis to make, but if chronic endometritis is not treated, then your pregnancy rates are definitely going to be low. In fact, what we found is that the natural vaginal flora is actually disturbed in these women. So the lactobacilli, which should be more, is actually reduced, and the other pathogenic bacteria, which should be low, are actually reversed, and they are much higher in these women, and they have seen that the pregnancy rates is much lower in them. So if I were to give you a snapshot of what works and what doesn't, as you can see here, embryo glue, yes. Assisted hatching doesn't work. Artificial oocyte activation, I will describe that to you in a minute, and we still haven't figured out whether it's actually working for us or not. Improvement of blood supply in terms of RG primes, the RG prime medications, or the sildenafils, or the vitamin E's, or the aspirins. All of these are the vasodilators that we sometimes tend to use when we see women with thin endometrium, or we do not see a good vascular supply to the endometrium. For them, when we are giving them these medications, it does seem to make a difference in terms of implantation. Antioxidants, like we already spoke about in terms of CoQ, melatonin and vitamin D, it does have a place. Immunotherapy, we still don't know. Immunological reasons for recurrent implantation failure or recurrent pregnancy losses, we still don't have a great clue as to how to treat them. Frankly, we don't have enough investigations to do to see whether they have an immunogenic problem for us to actually treat them, because treatment is wide. Steroids, you have immunoglobulins to be given. You can actually give them TNF alpha and antagonists to treat them. But we don't know who needs these treatments. And all of these treatments are not as simple as giving an aspirin. They come with their own side effects. So this is where we are actually stuck, because we really don't have enough knowledge about the immunochemistry in terms of how do we, assess and how do we pick up these patients who have immunogenic issues. Then we are talking about DHEA, like I said, which has shown to show benefit. Growth hormone, no, except for the specific groups that we spoke about. We used to do a lot of endometrial injuries, but that doesn't work anymore. We are talking about chronic endometritis, definitely has a play in terms of improving your implantation. Atosiban, we still need much more data before we can actually say it's made a difference in terms of live birth. Now, that is as far as all the other aspects are concerned. Let's move on towards Dr. Krishna's territory, which is embryology. And when you really look over the last few years or few decades, there has been a great sea change when we are talking about media and cultures. We used to do a sequential step, in terms of media. Now we have completely moved on towards a single step media. In fact, the skill that is required for an embryologist is slowly, we are trying to bring it down to bare minimum. Now, also, when we are talking about the incubators, we have greatly moved on from large box incubators to tabletop incubators. And here, if you don't have to remove, open the door of the huge incubator and disturb the culture that is going on for so many patients. You have just one little box in which you open, you just manage and evaluate the embryos of that particular patient, and you're not disturbing, the embryos of the other patients. What has actually come up, and this is where we are at this point in time, is time lapse. Now, this is a great invention, extremely great to watch as well, wherein even without removing the embryo from the incubator, you're able to assess the quality of the embryo and the way it is dividing. Why is it important? Because these dynamics of an embryo is what will help you select the best quality embryo for you to go for a transfer. So where, what is the division being like? What is the timeline that it's taken that division to take? If it follows the actual algorithms, then we'll be able to pick up that particular embryo which has a higher potential for creating a pregnancy. But has that helped us in terms of actually, improving our live birth rates? Probably it has reduced the time to pregnancy, but if you're looking at the cumulative live birth rate, it still hasn't made much of a difference. I still think there's a lot more that we have to learn about this machine before, we can say it's making a difference to us. Laser-assisted hatching, like I said, it used to be done quite a lot, but now we have realized that its function, again, is in very few conditions, that is enabling us to do pre-genetic diagnosis. Now, vitrification, there is no lab that can be called as an IVF or a fertility clinic if you cannot offer vitrification. Vitrifying oocytes, sperm, and embryos has to be there. That is the basic minimum that an IVF lab has to be providing. And again, when we are really looking at the evolution of vitrification, we went from slow freezing, which used to be done in big box-like structures, to now reaching a point wherein we have automated vitrification devices, wherein if you just put the embryo into that particular device with the media, the machine does everything in terms of actually loading it onto the device and freezing it for you. So we are trying to automate it. Everything is looking at automation and trying to reduce the burden of the embryologist here. What about, the confusion? You still tend to read, even now in 2021, you still have newspaper articles telling you that, there was a mishap wherein the embryos were mixed. You have a Caucasian getting pregnant with a black child and vice versa. Why? Because ultimately, most of the work that is done in the lab is done by humans. And we can never completely eliminate human errors, which is why, again, we are looking at how do we automate it. So electron witnessing system is one way in which everything about that couple actually has a barcode. So all the dishes are labeled, And even when you remove one dish and you have that electronic monitor, it tells you whether you've got the right patient's ID. So you check the ID of the patient, it records that, and then whenever you remove the dish, it tells you whether it's got the right patient's embryos, oocytes, or sperms. This has reduced the human error which otherwise could have happened. In fact, we have enabled our own electronic witnessing system, which has been devised by our own IT team here, like quite a few other inventions that Oasis is known for. PGT. Like Mr. Sudhakar was telling you, our database for PGT is probably the second highest in the country, because we have been doing this for the last 7-8 years, and there are quite a few publications in international journals when we are talking about the efficacy as well as the implementation of PGT. Now, PGT-A is checking for aneuploidy, particularly to be useful on couples who have recurrent implantation failure or recurrent pregnancy loss, particularly for women who are more than 37, 38 years. This actually has reduced the time to pregnancy for us. It has reduced miscarriages for a woman and has made a great deal in terms of understanding why some people don't conceive even when they have had the 4 or 5 embryos that should have got them pregnant. There are quite a few disorders for which, traditionally in the past, people were told to go for either donor egg or donor sperm. But again, like I said, a good fertility clinic should try to aim for the couple to have their own genetic child. And with the technology that is available now, with so many genetic disorders that are there, we actually are able for us to pick up those embryos. Thank you very much. We are able to pick up those embryos which have eliminated that particular genetic disorders. Now, next is omics. What is omics? Is actually understanding about that particular embryo is not just about just the chromosomes. We are going deeper than the chromosomes. We are looking at the translations into the proteins that it is secreting, whether they're actually there. What about the metabolic and the metabolic compounds that the embryo is secreting? Are they the right ones? Is there any disease that cannot be picked up in PGTA? Now remember, PGTA doesn't pick up everything. That's just like, giving you a complete set, whether the whole set of chromosomes are there. It doesn't tell you about the genes that are particularly responsible for some of the disorders. If you do not know the genes, if you know the genes, yes, you do PGTM. But what about the genes that you don't know of? Towards that is where we are looking at in terms of the omics. And towards that, again, when we are talking about PGT, the thing that scares most of the clinicians is, are we damaging the embryo? And PGT can only be done if an embryo becomes a blastocyst. What about the embryos that don't become blastocyst? Don't they have any capacity to create a pregnancy? Are we actually overruling the fact that, just because an embryo becomes a blastocyst, only that can create a pregnancy, thereby losing quite a few embryos? So all of this has actually led towards, again, trying to make it as less invasive as possible. And that is called as non-invasive PGT. Like how you have the NIPT, we have the non-invasive PGT. Here what we are doing is we are looking at the media in which the embryo is growing and take that little media and see the compounds and the different factors that that media is containing to tell us about the health of that particular embryo. A lot of research going in, and possibly within the next 5 years we will be able to actually offer this instead of PGT. IVM, this is a special baby of Oasis, and in fact we have collaborated with a very good group in Europe which is actually known for IVM, because we feel that in India we have the need for IVM to work. It is cheaper, it can replace IUI for you, it can reduce the cost in terms of multiple times that the woman has to undergo treatments. Yes, it is particularly for PCOS, but if you really look, 1 in 5 women who come to a fertility clinic are PCOS. And their journey tends to be extremely long. So for us, if IVM works for a woman, if it gives us the same pregnancy rates as IVF, then we have cracked it for them. And this is why we have started this collaboration with a European organization, and we are actually offering IVM. And probably in a year, we'll have much more data to give you. Talking about fertility preservation, I mean, again, like I said, unless a fertility center can provide vitrification, we are really not doing the job. And in the same breath, we also have to say that every fertility center right now should also be able to provide fertility preservation. This is where, because quite a lot of women in their reproductive years are being diagnosed with malignancy. And the survival rate and the way that chemotherapy or radiotherapy or whatever treatments that they are having is giving us such good cure rates that later on in life they would want to have a family. And this is where, as fertility specialists, particularly in conjunction with the oncologist, we have to be able to offer them fertility preservations. Now, this is also something that hopefully within the next 2 or 3 years we should be able to offer, and that is ovarian tissue vitrification. There are more than 100 births in the world with this concept. And here what is happening is we are not even taking the women who have malignancy through IVF. We are just removing a cortex of their ovary and vitrifying that. And once they finish their treatments, the same ovarian cortex is again reimplanted in the ovarian fossa or on the ovary itself. And therefore, they're no longer menopausal because it's secreting the hormones, and they also can conceive either naturally or with IVF, with their own oocytes, rather than again going for donor. Unfortunately, like how ovarian tissue has given us, a great deal of success, testicular tissue still hasn't reached that part yet. We still have to rely on sperm vitrification for that person to actually have his own genetic child if he were to get his own genetic child. Now, this is, where a lot of work has already gone on. What is it that we should look forward to in future? Actually have a robot do your ICSI for you, do your vitrification for you. In fact, recently I read a paper in which in AI, they're going to get the machine to actually pick up the oocytes in the follicular fluid that is going to be given to them. So the fluid is going to be put on the table, and the robot is the one who's going to be picking up these oocyte cumulus complexes, separate the cumulus and put it into another dish. So much of AI is actually going to be utilized in this field of fertility. So imagine machines, everything. Pickup is done by them, vitrification is done by that, time-lapse is telling you about your embryo. So the embryologist just has to sit on his desk and tell us which embryo, look at the algorithms and tell us, which embryo to put back. Don't like injections, nobody likes injections. Are we towards looking at oral hormones? Yes, there's still a lot of work being done. They're still on phases 1 and 2. A lot more work is still going to be done, but hopefully we'll get there soon. This is not going to be possible in India because of PCP and DT, but this is where in some countries, in remote areas, the women are actually given an ultrasound machine, that they do their own ultrasound, upload the images to the fertility center. They'll tell them the dosage that needs to be taken and tell them what time they need to come for egg pickup, which means that only one visit in which they come for the egg retrieval and one visit for the embryo transfer. So all the monitoring is going to be done by this self-operated ultrasound. Can we get oocytes? Can we get sperms for somebody who cannot or who's gone into premature ovarian failure? Well, till now, where research has gone on is we have been able to turn skin cells into mature oocytes. We have reached that stage in humans, but we haven't got to that point wherein the mature oocytes have fertilized. So we have got one step into the ladder. We still have a lot more steps to go, but again, if we have reached this, we might reach further as well. And this is where we are talking about in vitro activation of oocytes, wherein in women with very poor ovarian reserve or with premature ovarian failure, there is this concept of in vitro activation of oocyte, wherein we take a bit of the cortex of the woman and it is actually chopped into pieces because there is a kind of hyposignaling pathway that goes on in terms of oogenesis that is disrupted. And therefore, the cycle of folliculogenesis actually restarts. So they do that, they do some chemical activation as well with those pieces of cortex that has been chopped up and again reintroduced back into the ovary. It is being tried in some parts, mostly a lot of research is coming from Japan in this particular area, but again, we still need more work before it can actually take into practice. PRP. Not a great advocate of PRP because I don't know whether it's a hit and miss game that we are playing with PRP right now. So it hasn't completely replaced or treated Asherman syndrome or even women with premature ovarian insufficiency where PRP is injected into the ovaries. Yes, possibly, again, one step onto the ladder, but we still have a lot more to do to understand this efficacy in terms of fertility industry. What about sperms? Sperms, we have actually gone a little step further when it comes to sperms rather than oocytes. Here we are able to get a mature sperm and even fertilizations have occurred. But again, embryo development is not something that we have seen in humans, but yes, we have seen it from mouse. You must have heard a lot about this 3-parent baby. Now the concept behind this is when a woman gets older, obviously the nucleus is fine, but the cytoplasm in terms of the organelles, the mitochondria, it is not as healthy as it should be as when she is younger. So what we tend to do is, because the nucleus is where you have the genetic material of the mother, we leave that, we change the mitochondria and all the cytoplasm from a woman who's much younger, so that we get a much healthier cytoplasm with its organelles, with the woman's genetic material, and use that to create embryos. So that women, even whose oocytes have got extremely poor quality, are able to actually generate embryos with their own genetic material. CRISPR, this is gene editing, and frankly, the concept behind this is being very noble, in which you're trying to actually cut and remove the genes which are pathogenic. But somehow this went into the wrong concepts, and people were trying to misuse this technology, and one clinician actually tried to eliminate HIV in the embryos by using this technique. He succeeded, but what happened was those children's lifespans were very short. So yes, technology is there, but we still need to understand the full implications of what this technology is going to do for us before we can actually offer it for routine use. The last and not the least is, what do we do about the uterus? We are looking at the eggs, we are looking at the sperm, we are looking at the lab, we have seen so much development going on there. But once an embryo is created, if the uterus is not ideal, if the endometrium is not ideal, what do we do? Yes, you're trying transplantation, but again, that comes with its own issues. Surrogacy, again, if the law was to take hold in India, which may not be, it might not be possible for everybody. So the future is looking at actually having a womb outside, which means that you will see your baby growing in your drawing room in this kind of container that is going to give the fetus the right kind of environment and the right kind of nutrients, enough for it to actually develop. Long way to go, but a lot of research is going on in Europe regarding this. So when we are talking about fertility, we are still getting future ready. And long way to go, but we are still struggling hard, and we hopefully in a few years' time, probably looking at how 1978 was to how 2021 is when we are talking about fertility, possibly in another decade, we could be looking at completely different picture of providing fertility services. Thank you very much.